Hello and welcome to Think Like a Clinician question 91. A 10-year-old boy with a history of sickle cell disease presents with severe pain in his legs and back, and he has no fever or cough. What is the most appropriate initial management? A. Intravenous antibiotics. B. Hydroxyurea. C. Hydration and analgesia. D. Exchange transfusion. Take your time, think about the case, and provide your answer before we go into the case discussion. Now, if we look at the case from a clinical standpoint, we have a 10-year-old male with sickle cell disease presenting with a vaso-occlusive crisis. He's experiencing severe debilitating pain in his bilateral lower limbs and lumbar region. If we can get like a quick recap, his pain score is somewhere around 9/10 or 10/10, given the severity of it. Stable respiratory system, given that there is no cough, and also there's no mention of the SpO2 or the oxygen saturation. Infection screen could be negative. He's a febrile in this case, so we're not suspecting any kind of infection. And there's the aspect of hemodynamic stability, which has not been mentioned quite well, but we can also relate to. So in the acute setting of a vaso-occlusive crisis, the clinician's priority is a dual TLAC approach. Number one, you want to do symptom control, and number two, you want to do reversal of the pathophysiologic trigger. So here's what we're going to do. The 60-minute goal. International guidelines, including the WHO and various Ministry of Health protocols, emphasize that the first episode of analgesia should be administered within the 60 minutes of arrival and ideally within the 30 minutes of triage. Number two, addressing ischemia. Since the pain is caused by microvascular sludging of sickled cells, management must aim to decrease blood viscosity. This is achieved through adequate hydration, which helps, quote unquote, unstick the cells and provide distal perfusion. Number three, psychological impact. Severe pain in pediatric patients triggers a sympathetic fight or flight response, which can cause further vasoconstriction and worsen the crisis. Rapid, effective pain relief is a physiological necessity, not just a comfort measure. Number two, we need to look at systematic, now in the case of how we're breaking down this case, systematic justification. Why not the other answers in this case? So why not simple paracetamol alone, if you ask yourself? For a patient reporting severe pain, okay, a 9/10 or a 10/10, paracetamol or standard normal non-steroidal anti-inflammatory drugs are insufficient as a monotherapy. They may be used as adjuncts, but severe vaso-occlusive crisis requires parenteral opioids, something like morphine or fentanyl, depending on what's available to you. Why not prophylactic antibiotics? Although sickle cell disease patients are functionally asplenic, okay, they do not have the spleen, or like they have the spleen, but it's functionally not there because of the microvascular damage and prone. So although the sickle cell disease patients are functionally asplenic and are prone to infections, this patient is febrile and has no focal signs of infection. Starting antibiotics without a clinical indication contributes to resistance and does not treat the primary issue, which in this case could be ischemia. And again, you ask yourself, why not oxygen therapy? Administering oxygen therapy to a patient with a saturation of 98% is not indicated. Now, in this particular case, we were never told about the saturation, but we made the assumption that this patient is breathing well, and we got to a saturation of 98%. But administering oxygen to a patient with a saturation of 98% is not really indicated. In fact, excessive oxygen can suppress erythropoietin, potentially worsening anemia in the long term. Oxygen is only indicated if the saturations drop below 92% on room air or if there are signs of acute chest syndrome. Now, you might ask yourself, why not immediate blood transfusion? Transfusion is reserved for specific complications such as stroke, acute chest syndrome, aplastic crisis, or severe symptomatic anemia. In simple vaso-occlusive crisis, transfusion increases blood viscosity, which could theoretically worsen the vaso-occlusion. Now, if you look at it from another broader perspective, the analgesic ladder in sickle cell disease. For severe vaso-occlusive crisis, the gold standard is the use of individualized opioid protocols. If the patient knows what dose works for them at home or from previous admissions, start from there. Always remember the 1.5 maintenance rule for hydration in vaso-occlusive crisis, providing intravenous fluids at 1.5 times the calculated maintenance rate helps reduce blood viscosity, but clinicians must monitor closely for fluid overload, which can precipitate sometimes pulmonary edema and mimic acute chest syndrome. So in summary, number one, we want to do rapid analgesia, that is immediate intravenous or subcutaneous morphine, 0.1 milligrams per kg, or you use whatever opioid is available to you. Number two, hydration. You want to think about IV fluids such as normal saline or 5% dextrose. And again, the 1.5 times maintenance rule. Number three, you want to also look at the non-pharmacological aspect, which is the warm blankets. Sometimes cold can be a trigger of sickle cell, vaso-occlusive crisis in sickle cell. And also you give the patient a calm environment. I hope this helps and also made you understand the case a little bit better. See you in the next question.